Welcome. I'm Dr. Lloyd Sederer at Columbia Psychiatry, reporting for Medscape. Today, our guest is Dr. Jeffrey Lieberman, Chairman of the Department of Psychiatry and Professor at Columbia. Our topic is going to focus on mass violence and some of the consequences, long-term consequences for the individuals impacted that survive on their lives and on their biology. Jeffrey, welcome.
Thanks very much, Lloyd. Good to talk about this.
Teach us about mass violence. How is it defined? How do we understand what's going on in these instances?
Well, mass violence is very specifically defined as perpetrated against more than a number, and it's an arbitrary number, but it's 3 or 4 individuals. Often it's done against random strangers, in other words, not people who are known or there's a specific grudge or reason for it. And it can occur in a public setting, in any type of venue, not necessarily in a home or not necessarily in a place of crime. Mm-hmm. It's a particularly pernicious kind of crime, which actually, despite the fact that it's shocking to the public, it's widely portrayed in the media, and it has effects that resonate on its victims for a long period of time. It only accounts for a small amount of all violence crime, but it's such a random, senseless, and horrifying type that it has consequences way beyond the specific numerical loss of life.
And that's part of what's so unsettling about this for everyday people, is that it's random. You don't know when this could happen, and it's not. It's different in that respect from domestic violence or being in a tough neighborhood.
It's really the civilian or domestic equivalent of terrorism. Because its shock value exceeds its the loss of life. But pertaining to Columbia Psychiatry and ourselves as psychiatrists, the relevance also is twofold. One, even though people with mental illness account for a very, very small proportion of violence in our society, 4% or less of all violent crime are perpetrated by people with mental illness. People with mental illness disproportionately perpetrate mass violent crimes. And this is when individuals suffering from a very small number of diagnoses are untreated or ineffectively treated.
These are psychotic conditions.
It can be psychotic conditions, it can be a mood disorder, it can be PTSD, or it can be aided and abetted by substance abuse. And these occur largely when people are impelled by their symptoms, as opposed to motivated by, I'm going to steal money, or I'm going to settle a grudge, or I'm going to engage in some kind of organized crime or gang warfare. The other part of it that's so pernicious is the fact that the effects that it has on people, not just the people that get injured as a result of it, but those that are in proximity and those family members of the individuals who are affected by it, all suffer the consequences in the form of experiential trauma.
One thing I've learned in my work, is that the impact of a disastrous event, whether it's a natural disaster or a mass violence, is highly related to your proximity to the event or to the person. So we're talking about people who witness these events and people who are related to other people who are victimized. What about the general public? Is there such a thing as PTSD for the general public after a mass violent episode?
Well, not really. I mean, it's like going to watch a horror movie. You're affected by it, and even when you come out of the theater, you may have some lasting thoughts about it, but it's not anything that's usually as intense or that distressing or disabling. However, there's really 3 variables that determine the effect of a traumatic event on an individual. One is how intense the event is. If you're in an earthquake, if you're in a terrible fire, an auto accident, in the theater of war, in a firefight, or in a mass violent incident. Second is your proximity to it, and then the intensity of it. And then the third thing is your inherent resilience or susceptibility,
Yeah.
because some people are able to basically shake this off and without any kind of lasting effects. Other people are indelibly altered for weeks, months, years, or even the rest of their lives.
Recently, there were 3 suicides. Two people who had witnessed the Parkland, Florida murders, and the father of one of the children at Sandy Hook. How do we understand those long-term consequences from a disaster? How do teach us about what's happening in the psychology of that person and in the biology of that person?
Well, coming back to your former question about the public and how they may be impacted on it, even if they're not in immediate proximity, the other thing is the media. The media reifies the effects of a mass violent incident, and that pertains to why you may find the kind of delayed consequences occurring, and also the fact that the consequences can be distributed far and wide from an incident. So here you have the father of a victim of Sandy Hook who's responding to an incident that occurred in Florida.
Yeah.
Sandy Hook, Connecticut in Florida. Why? It's because the cognitive information about what was going on in Florida reactivates the emotional trauma that they had. And this is really the pathophysiology of trauma, which has been terribly understudied, underemphasized psychopathologic condition. And the thing is that it's hard for people to appreciate the fact that when you get injured, whether you twist an ankle, when you bump your knee and you get a black and blue mark, or whether you get an infection, everything has a physical cause.
Yes.
So how can something which is intangible have a deleterious effect? Well, that's because the brain is this marvelous organ which is susceptible to it. And the brain is very resilient in being able to manage all the stresses and the challenges and the vicissitudes of daily life, and when you have to meet demands and so forth. And it is able to re-equilibrate, but it has its limits. And
what happens in the brain? How do the viewers understand what's changed in the brain for those who aren't resilient, who suffer the trauma?
They're perceiving sensory stimuli that are comprise or describe the experiences they're having, and they process it in the brain. And if it's deemed important enough to store in terms of long-term memory, it's encoded in the hippocampus in the form of a protein. Those experiences where there's an emotional component are also encoded. Now, when the experience is of such emotional intensity that it becomes overwhelming, it's difficult for it to be contained in a way that's outside of consciousness, because you can't have in forefront of your mind all the things you've ever done in your life, so you have to be able to store it away and just retrieve it whenever you need it. But if some things are just so intensely emotional and distressing, they can't readily be controlled in the same way. And the process by which this is intended to be done is through the frontal cortex exerting what's called cognitive control over subcortical structures, and in this case the medial temporal lobe, hippocampus, and amygdala. So the event with this intense, disturbing emotions are things which pervade into consciousness and can't be put out of mind and induce distressing effects, whether they be hypervigilance, whether it's anxiety, whether it's anger, and so forth. Now, the question is then, apart from avoiding massive experiential trauma, how can you treat that?
Yes, yes. And this has to do with some of the triggers of work that focuses on the triggers to that emotional reactivity, cognitive therapy, medications. Can you say a little bit about what are the effective approaches to a persistent trauma?
Well, we do a terrible job at managing the effects of traumatic experiences. If you think about how public health is advanced, sanitation, smoking in public places, nutrition, exercise, terrible. We do nothing to manage it. And what I mean by that is that we have treatments that are sensibly used for PTSD, you know, whether it's medication, whether it's desensitization, whether it's CBT. These are minimally to moderately effective at best.
Yeah.
But in thinking about it, if there was really a intensive and enlightened effort, which should have begun in the Defense Department and in the military, you think about it in the sense that what is the etiology of this condition? Well, it's the experiential trauma. Well, you know, if you're in war, you're not going to get away from that. But are there things you can do to immunize people against the effects of intense experiential trauma? Or if they have been in a firefight, if they are really shell-shocked or traumatized, before the event is translated and coded into long-term memory, can you do something to disrupt that? And then if it's too late, it's already encoded, then you've got to figure out a way to desensitize it or relieve it. Now, military medicine has been miraculous in its progress. You know, people that used to die on the battlefield from wounds now are saved. They have medics, they have field hospitals, they transport them to Hospital Wiesbaden in Germany, and then if they need to Walter Reed. What do you do for experiential trauma?
Yeah. So this is where the field needs to go in terms of what you call the immunization, protecting people against the kind of trauma, the kind of exposure, that life-threatening exposure they're going to have, and early intervention, identifying those who are at risk and helping them not make this a permanent part of their life.
And it's not just the military, first responders, fire, police, or victims of muggings or accidents. You know, when you come to an emergency room and they minister you for whatever your physical injuries, do they minister you for your psychological injuries? No. And the amount of research that's focused on developing these interventions at all these different stages is minimal. So one of our faculty, Christine Denny, Renee Henn, have been focusing on a line of research which identifies, and you can do this in animal models, one of the, probably the two conditions in the DSM that are most validly modeled in non-human species like rodents are trauma and addiction. So they can model trauma and PTSD with fear conditioning, and then they can use different pharmacologic manipulations to see if you can inhibit the consequences of fear conditioning
before it sets in firmly and persistently. Well, thank you for teaching us so much about this and about the work that your department is involved in terms of making things better in the future. Thank you for joining us. I'm Dr. Lloyd Sederer here at Columbia Psychiatry, reporting for Medscape.